Hey guys, so welcome to this is our fourth monthly Treat IR live case here at Mount Sinai. I think we have an interesting case today. Joining us also is a guest moderator is Covey down at University of Alabama, Birmingham. I don't know if they see you. Do they see Covey? All right, hold on. We're gonna get Covey on in a second. There we are. All right. And I'm going to introduce the team. I think we have Dr. Aaron Fischman, Dr. Kirema Garcia-Reyes, and Dr. Tim Carlone, who's going to introduce the case and the team. So Aaron, to you.
Good morning, Rahul. Good morning, everyone. Thank you for joining us today. This is our fourth case in the live case series at Treat here at Mount Sinai. I'm here in room 1 with Dr. Garcia-Reyes and Dr. Carlone, as well as our esteemed tech, LU, and Joanna, our nurse, and our anesthesiologist, David. So I'm going to ask Tim to present the case for you guys so we can get started.
All right, great. Good morning, everybody. It's great to be here again. Let me swap spots.
Yep. That's fine.
Yeah. All right. So hoping everybody, it looks like everybody can see the slides here. So we'll be presenting the fourth case in this series, and this is an embolization of a renal angiomyolipoma. Next slide, please. So our patient today, she is a 50-year-old female. A couple of, prior medical issues, but nothing major recently, asthma, hypertension. She initially was found to have a couple of renal masses when she had an ultrasound done incidentally while she was pregnant back in 2017. And then she's had some follow-up imaging showing these AMLs slowly growing, and that's how she came to us on sort of standard medications for hypertension and her asthma. Next slide, please. So when she came and saw us in the office, her exam, vitals within normal limits. Her exam is unremarkable. She has no symptoms related to this, and she's never had any back pain or bleeding related to this AML. Her kidney function is normal, and her labs were within normal limits. So we repeated the renal protocol CT because it had been a couple of years before she came to us. And she's got 2 large left lower pole masses, both over 4 centimeters. So go on to the next slide, please.
Perfect. Thank you.
Okay, so this runs through pretty quick, but we've got still shots afterwards. So as we came through, you can just go back and then play this slide again, just so we can see that run through. No vessel tortuosity here, single left renal artery on both sides, and those 2 left lower pole renal masses. So next slide. We can see we've got sort of a bilobed, but 2 separate masses at the anterior left lower pole, and they're both very vascular AML. So there's macroscopic fat, but a lot of vascular supply there. Next slide, please. And this is what it looks like in coronal, and just showing that single origin. So our plan, we discussed in depth with her all of her options, including surgical resection, continued observation, and embolization. And Aaron's going to get into a little bit more of what we were discussing with her and what our treatment plan was. But our plan is a transradial approach embolization today.
All right, thanks, Tim. So as many of us know, when we treat AMLs, there's a lot of options here. So I'll just tell you guys what we've done so far. We used a 5 French serraradial, 110 centimeters, and we put that down into the left kidney. We actually did a DSA at 4 for 16, and we have this picture here. You guys can see this on the screen. So when you look at these angiograms, sometimes it's challenging to find the AML vessels, and sometimes it's not. I think in this case, it's very obvious that there's one very large vessel medially that's feeding that medial tumor. And then we were sort of looking at this angio for a little bit and trying to decide before we put a microcatheter in which was supplying the other AML. And as is a standard practice of mine, I'll typically go into the harder vessel first and save the easier one for second if we have multiple vessels. And so I think in this case, and I'm going to ask you guys to comment on this, which vessels do you guys think are supplying this AML if you had to guess? I'm going to just go through it a little bit more. She's getting propofol, so she can't really hold her breath.
Yeah, so to me, it looks like basically all the lower pole branches. Like, I don't know how.
Okay, that's an interesting thought. That was not my initial thought, but what do you think, Covey? Because we don't really know exactly yet, but we'll show you.
I think definitely that medial one in the lower pole is supplying that medial AML. Yeah, I totally agree. The lateral one, I'm a little bit not sure. I mean, my, for me, I just like to select them out individually and then check and either see those characteristic AML branches or you don't. So,
Elliot, can you put up the drawing on the screen again?
So why don't we back up a little bit, Aaron? So in terms of like, how do you decide when to treat these? The classic is the 4 centimeter size, right? Now, if she had 2, but there were 3 centimeters in size on the same kidney, like, what's the?
Yeah, so the standard practice, and if you talk to even urologists that take care of these and you refer patients, the standard practice is above 4 centimeters is where we would consider embolizing them, but a lot of that literature is not necessarily based on imaging features and CT images suggesting that maybe these lesions are more or less vascular. So as an example, if you have somebody who has a 3.9 centimeter very vascular AML, I'm not sure that ignoring that would be the best solution. Whereas if you have somebody that has a 5 or a 6 centimeter, but it's mainly just fat on imaging and very little vascularity, you could also make the argument that maybe you don't need to treat that so quickly. I'm curious as to what you guys think about that.
I think just to add something, Aaron, I think in this case, the growth rate was also important. So she actually, if you have an AML, that's pretty vascular and it's grown a centimeter in a year, then you get more worried about future rupture.
Yeah. I've seen AMLs rupture that are 4 centimeters, and it can be very devastating for the patient, obviously. So you definitely want to treat them if you see them and they're very vascular, I think is a general rule, but obviously the growth is important too. I'm going to draw on the screen here in a second. Let me see if I can do this. Oh, you keep going. I'm sorry. You keep talking, Covey. I'm just going to keep.
No, you're fine. You're fine. I think all great points. I mean, I think by convention, most of us probably still treat over 4 when they're fatty predominant. Although, your point is very good, Aaron, about, maybe we don't need to, but, the growth aspect is important as well. I'm curious, if you have an AML that's a little bit oddly shapen and you measure 5 by 2, right? 2 centimeters in that kind of short dimension. What would you do with that?
Well, that's exactly my point and why these numbers, and again, it's the same thing with aneurysms, right? If you measure them in one dimension and you don't do it in the center line measurement, is that really the most accurate way to do it? I think the size is probably not as important as how vascular it is and how fast it's growing.
Agree.
And that's just something that we just really don't have a definitive answer on. But if you just go by literature, 4 centimeters is probably where we would most of the time try to think about treating it. I'm going to draw on the screen here. This vessel jumped out at me a little bit. Right here. Do you guys see that?
It's not drawing.
Try it again. Redraw.
Yeah. So while
right there.
Aaron tries to draw. So the other question is, this is unilateral, but
you guys see that?
Yes. Do you ever screen your patients for, tuberous sclerosis or some sort of syndromic issue?
Yeah, I mean, we have imaging. We started with a CTA. There's no other lesions on this patient. She has no family history of anything of the sort. But absolutely, especially when you have multiple AMLs, you have to think about that. But these are small on the small side. Typically with tuberous sclerosis, in my experience, they tend to be bigger. So this is the purple line here. And that vessel jumped out at me a little bit because what I described it as almost non-anatomic. And if you go back and just look at this angio again, that vessel doesn't typically, a normal kidney doesn't have a vessel that makes that turn. So we were attempting to get into that vessel before we went live. And now we have a microcatheter. This is a True Select. We started with a True Select, but we have other options here. And we did an angiogram here, and we don't really see that vessel so well. So I think what we're going to do now is we're going to zoom in a little bit and do another angio with a 3cc medallion, and we're going to take a look and see what you guys think of the angio here.
Can you delete that from our
How do I
screen?
delete that? Remove. Here we go. Okay.
Remove.
Zoom in one. Okay. Try that. Let's do that. So we're going to do an angio here. So there it is. So we do see it now.
So Aaron, we typically embolize these. Obviously, you're going to embolize it here because that's what we're showing. But other people have discussed doing alternative treatments such as such as embolization or partial resection, or not embolization, sorry, ablation and partial resection. How do you decide?
I personally think embolization is the least morbid. With especially when you're doing ablation on a kidney and a large lesion that's vascular and has surrounding structures, I think embolization, in my mind, is the least invasive, and I would always start with that, unless I didn't think that I could, embolize it effectively. But again, if the lesion's not that vascular, it probably doesn't need to be embolized anyway. So I personally do embolization for almost all of them, unless there's a reason why I can't. When I look at this angio, guys, I'm not exact. There's another vessel, obviously, which we saw that's coming off more proximal. But now we have multiple feeders here. So we have this little feeder that goes to the medial branch, which I think we probably could get into. Mm-hmm. And then we have this other one that's a little bit more distal. Do you think it makes sense to try to catheterize those, or would you just take this whole lower portion? Go through that again.
That's a great question. I mean, I would try to be a little more super selective.
Let me try to get into it.
Sometimes
let's do that while
challenging, but that's what I would do. I mean, remind me, Tim, this was a young female, right?
Correct. 50-year-old female, but like very, very healthy.
Okay.
We're chatting with her,
we want to preserve as much, as many nephrons as possible, right?
Exactly.
That's always the idea here.
And I think to Rahul's original question, I mean, that's a great point. Like, if you can't get into one of these branches, and you're not sparing that much normal kidney, or you're taking a little bit more normal kidney, maybe that's where some of these other treatment options come into play.
Yeah, that's a great point. We have a couple options here in terms of microcatheters. This is a True Select, 155 centimeters, because we're from a radial approach. We also have a 150 centimeter sniper, which we were thinking about using for that bigger branch there, more medial, because it was off the main trunk and we wanted to potentially prevent reflux. So I think we're going to try to use that for that branch. And then with this microcatheter, we're going to try, if we can, to try to get that tiny little branch there. I think if we go down that main trunk, we'll probably have a better chance of getting into it. You also see that we have a little bit of buckling of the microcatheter further up. So in theory, we could put this base catheter a little bit further in if we wanted to give us more support. I also think we probably need to recurve the micro wire
give you a different curve.
to get a little bit better angle. So what Tim's trying to do is leave this microcatheter a little bit more proximal, and then we're going to maybe take another picture from this spot, and then Kirema is going to reshape the micro wire. And maybe if you guys want to see the shape that she's going to use before we put it in, we can take a look. For these, I like to use, as I said in other cases, a question mark type shape. So we're distal to it here under the live fluoro, and there it is, a little bit more proximal. It's a little small, this vessel, and it's probably smaller than the microcatheter. So if we get into it, that would be great. If we don't, I don't think it's the end of the world. Yeah, it's a little bifurcation there, it looks like.
I don't know how you feel, but to me, that's like an acceptable amount of kind of normal parenchyma there to take in a situation like this.
Yeah, I think if you try to get too subselective, you're just going to end up missing parts of it. So
yeah.
So you guys would embolize from here?
So.
You can give it one more shot.
Yeah. Yeah, I agree with Rahul. I'll give it one more shot, but I wouldn't push it.
Lava here on the table, which we were planning on using, and I personally like using liquids for these cases. I think it's faster, and I think it's probably more durable. In terms of comparing different liquids, EVOH versus MBCA, I personally find that NBCA causes a bit more pain, and EVOH agents are much less painful, and the recovery is a little bit easier for patients. That is mostly anecdotal. It's not necessarily supported by the literature as much, but it's something that I've seen in the patients that I've treated. I'm curious. I know what Rahul would say, but I'm curious what Kavi would say, how he would treat this patient in terms of the embolic agent.
You're a little too selective
Yeah,
with your
and
mic.
I'm gonna date myself a little bit here, but yeah, I've actually moved to a lot of alcohol. I use a lot of alcohol in these situations. I found, I mean, I don't have lava on the shelf, so I've used a lot of Onyx, but I found I just in these small vessels, I have trouble getting it to push distally. But again, I don't have lava on the shelf, so no experience with lava. But yeah, I've kind of gone to alcohol, Lepidol, away from particles, and had good success there. I do pretty invariably, at least deep sedation, depending on the patient. But yeah, I mean, otherwise, post I haven't any significant issues. Most of my patients go home same day. The one of the quandaries I think is, what is the mixture? I tend to do 50-50, maybe a little bit more alcohol. There are a lot of people that will do 2/3 to 3/4 alcohol as well. So I think you have some variability, but it's interesting that you bring up pain. I have had patients when I put the DMSO in for Onyx, not in this particular situation, but just kind of jump off the table. I don't know if you guys have seen that at all, but I've kind of moved to a little bit of, when I'm embolizing a bleed with Onyx, I put a little bit of local Lido in, then I put the DMSO in, and that tends to be a little bit better tolerated.
Yeah, I find that the DMSO it just depends on how fast you inject it. So
Yeah.
you're supposed to inject it, unfortunately, painfully slow, and
Yeah.
so if you do really inject it that slow, they tend not to feel it. But like even for like type 2 endoleaks, when we've injected the DMSO too fast into a lumbar,
It saw
Yeah.
spasms.
it causes a lot of discomfort, and you're like, oh crap,
That's a good point.
yeah, back pain. But yeah, if you just go slow, it tends to mitigate that. With the lidocaine,
It's
the
more of an
problem is
aggressive
then
curve.
you do your run, you
do it?
inject your lidocaine, and then the vessel looks different because it's gone into spasm, because of the lidocaine. So,
That's totally true as well. Yeah.
yeah.
We're having a little bit of difficulty getting into this tiny branch. It looks like it's probably the size of the microcatheter or a bit smaller.
Try one more
I'm
time.
going to try one more time with a slightly different curve. It looks more like a tighter question mark shape. I don't know that we could get into it.
Honestly,
I think
I would embolize from here, but let's see if you
the
want
other
to
thing
go.
that I was thinking about, and this is an important point about the type of embolic. If we embolize even in that vessel with an end-hole microcatheter, it almost certainly will plug very proximal and not necessarily go as distal. So we're probably going to end up refluxing into the parent vessel anyway to some degree. So I don't even know if it makes sense, and it's worth our time to just be cute here and try to get into that tiny branch.
I 100% agree with you, Aaron.
I'm glad you
Yeah.
agree.
Agreed.
For use.
All right. And then
That's different.
there's also another
He's in
branch
it,
a
he's in
little bit more proximal that goes more lateral. And so we theoretically could just take the whole lower portion and just be done with it. But I think since we have these newer microcatheters that allow us to catheterize these tiny vessels, it does make sense to attempt to try to save as much kidney as possible. But we were going into this case knowing that we were treating most likely 2 large lesions, and it would probably take some kidney out with it. That looks pretty good.
Yeah.
Yeah, I think
I
this is a
think-
good spot because it's going to reflux a little bit, but it looks like we can get a good amount of embolic in there. That's great.
That's
I think
nice.
the other point too is, even if you took it from that
Nitro.
parent branch, I mean, there's an anterior and posterior here, right? So that's not the entire lower pole. I'm almost positive. So
Right. Yeah, exactly. The amount of kidney is very minimal.
David, we're
Yeah.
getting another
So-
bit of nitro into the.
Tim is giving some nitroglycerin here, probably 200 milligrams or micrograms, Joanna. And then Dr. Garcia is going to show you guys the lava setup over here. We already drew it up. It comes pre-packaged, and then Rahul can talk a little bit more about this in 2 and 6 millimeter kits, which is a little bit different than the other EVOH product that we have, which is Onyx,
I'll bring it
larger
over here.
volumes. And so if you're doing larger larger lesions or endoleaks and things like that, it can be advantageous to have a bigger volume when we do this. Rahul,
so
do you want to talk a little about that? Why Kirema shows it to us?
Yeah, so it's nice.
You see me here?
Obviously, it's very similar to I think what we're used to if you've used EVOH before. It's a DMSO, still DMSO based. It comes with the syringe, the polycarbonate syringes in a package. The 2 ml one I think comes with 2 Onyx syringes, which are the white ones. I actually like the syringes better because it has those nicer wings on it.
Yeah, we like the wings.
Yeah, I like the wings, but it's if you've used Onyx, it's the exact same stuff. It just comes in a little bit more IR friendly amounts.
Okay.
In 2 and 6 mLs. For endoleaks, I really do like the 6 mLs. You get a lot of it, and it makes the case go faster. You still have to shake it. The shaking times are a little different. There's also a mixing kit that comes with the you can use, so you can run it through. So I think it's you have to push it through like 20 times, and you have to do like 3 minutes of mixing or something like that. But
do you guys remember the dead space of the 155 True Select offhand?
0.56.
0.56.
Yeah.
Yeah, it's usually, most of these radial length microcatheters have a dead space between 0.46 and 0.6. So we're sort of right at that amount here. We're just trying to put in just enough to prime the catheter. We don't want to put in too much DMSO because the DMSO causes pretty significant vasospasm, and that's really our enemy with a case like this.
Right.
Any type of vasospasm is going to cause, it's going to not allow us to get as distal into this benign tumor as we want to. So Tim's going pretty slow. One of the things about the DMSO though is the DMSO is priming the catheter, just pushing out the contrast and the saline. When you inject the actual embolic, that's when you really need to go pretty slow, because that's when you're pushing out the DMSO. And so before you even see the EVOH, you're not going to know that you've created vasospasm until it comes out of the catheter. So I think that's an important technical point here.
Yeah, I mean, also you got to remember the lava. I mean, which you're using lava, I assume lava 18, right? Because it comes in the 2 viscosities.
This is lava 18.
Correct.
Yeah. We didn't mention that already, but this is 18. It's lower viscosity.
Right. So it's
we are now we're pushing out the EVO. We're pushing out the DMSO right now. And so Tim is looking at the CC markers on the syringe. So he knows exactly when he's going to actually see the embolic.
And you got to go, like we said,
and you guys
slow.
Frozen.
I mean, again, you can go faster depending on what microcatheter you're using. I will go faster with a balloon catheter.
Yeah.
And we're going to show you guys that probably next when we go into the other branch, and we'll see where we're at. And then the other portion of that tumor laterally might require maybe even a third treatment.
Yeah, I mean, the thing to remember also, lava and Onyx, basically the 18 and 34, the only difference between the two is the amount of DMSO mixed in with the EVOH, right? That's how they change the viscosity of the two, right?
I believe it's like 6% versus 8%, Rahul, is that correct?
Yeah, I think that's correct. Yeah. In Europe, there's a third iteration that's just not available here. I think it's like a 4 or something.
There's a 12.
Or 12, yeah.
There's a 12, I think, right?
Yeah, there's a 12.
And I thought lava also is a slightly lower tantalum concentration than Onyx, but
it is.
Don't quote me.
Yeah, it is. Although I have to say, in practice, I think the amount of artifact you get afterwards is still about the same, right?
Got it.
Yeah, it hasn't, or at least hasn't changed the amount of artifact that we see, that we still need to get MR follow-ups as opposed to CT follow-ups on these patients.
One of the things that we just noticed, and she's obviously pretty sedated, but she moved a little bit when we injected the DMSO. Oh, there we go. Look at that.
That looks nice.
Yeah.
Wow.
Yeah. I think part of the reason why it looks so good, Kavi, is that the microcatheter is sort of plugged in the vessel and almost creating like a wedge. So it's allowing us to penetrate really distally
without reflexing.
Yeah. And this is exactly what we want.
That's beautiful.
The other thing that bothers me about cases like this with the renal branches is you get this loop as it comes out of the base catheter, and that sometimes doesn't allow us to cannulate some of these angled vessels so easily. So I'm happy that we were able to get into this.
Yeah.
We're gonna just go slow, and we're almost done here, it looks like. But
I think we're reflexing a little bit.
remember, there was another branch that was feeding this from that more proximal. So it's possible that we can occlude that branch from this branch. I don't know that we will be able to, but it is possible since we're so wedged. We're going to wait a few seconds and then maybe inject a little bit more. But we did get a little non-target there on the side. Not worried about that.
I find sometimes that non-target isn't actually really occlusive, right? It's just sort of like a layer on the side of the wall.
I think we're probably done, right?
I think so too.
So Aaron, obviously this patient's not bled. How do you treat patients that are, come in, through the ER who've bled, right? So the sort of in the more urgent/emergent setting, do you still use flava, or would you use something else?
I don't think I would use EVOH in that case, because somebody who's actively bleeding, I would want to be as quick as possible. So in those cases, probably NBCA. You could also make the argument to use particles, but I would, our ideal agent here would be NBCA, given how fast it is to get a rapid occlusion.
I think we're done in this vessel.
Yeah, I think we're done with this vessel. So what we can do, I mean, we're probably not going to reuse this catheter. We're going to take it out and throw it out and then put another one in. But we're going to take this microcatheter out and then do another run through the base catheter. We were deciding when we started this case whether we were going to use a guide catheter or a diagnostic catheter, and we elected to use a diagnostic catheter. I think the advantage of using a guide in a case like this is we could leave the microcatheter in if we were unsure we had an occlusion, and then go back in if we wanted to, or go inject more without having to remove the microcatheter. But that's obviously not possible with this catheter. That looks pretty good. I mean, we have another vessel. I mean, we're getting really selective. So I think what we're going to do next is we're going to take the bigger catheter, and we're going to try to get into that vessel, the larger vessel medially. So right now we have a 150 balloon tip catheter, the sniper microcatheter. It shouldn't have an issue tracking around that bend, but what I think we're going to need to do is get the wire pretty deep in that vessel, and so we're going to use a 016 Fathom. You put that up as a roadmap, right?
So Aaron, I noticed you, in the first case you used a TUI. On this one, you're not.
Yeah. So the TUI with the sniper is not ideal because it can rub off the hydrophilic coating. It's a little bit of a technical nuance, so people that are not familiar with the catheter might not know that. What I'm going to do now is I'm going to pull the base back a little bit, and then we're going to push out the microcatheter, and this is going to allow Tim to get down that branch a little bit better, and then we'll re-advance it. We actually got the wire into this briefly before, so it shouldn't be too difficult.
Yeah.
No pressure, Tim.
A tighter turn last time.
So, Covey, have you used the balloon microcatheters? Do you use that in your practice?
Yeah, I mean, we traditionally have used a lot of snipers. We struggle a little bit with the back orders, but and so we're looking at the Scepters, which is a little bit new for me at the moment. But yeah, it's great catheter and great option for really kind of packing in embolic.
Yeah.
Anywhere, not just in the kidney, for that matter.
We've used the Scepter, the Scepter C, which is a neuroballoon from Microvention. They have some newer iterations. They have some different lengths and size. It's got some weird idiosyncrasies that I think are important for neuro, but not necessarily important for us, because it has like a dump valve and things like that. And it's a little bit more sensitive to the pressure. Like it's a little bit more prone to rupture than I've seen with the sniper. The others, I think the Scepter C is 014, right? So it's a smaller lumen. So if you're trying to do, like, some people use, the sniper for like Y90. I don't know if you can use a Scepter C for Y90. You may run into clogging.
Yeah, it's a great point. I mean, I'm looking at it more from like a flow redirection standpoint, and preserving distal branches, things like that, and then embolizing for more. Yeah. Exactly. In a double micro type system. But yeah, I think the ID was 0165, but I can't remember the sniper ID off the top of my head.
You can put 018.
You're right. It's a little larger.
Yeah, you can get an 018. You can get an 018 through the sniper. Yeah. And that, I think that's the inner lumen is 018. Yeah.
So a couple things about what we just did. Can you fluoro save that, LU? The the sniper catheter is very trackable, and it will track around these bends very easily. Some people feel that it won't, but it definitely will.
Replay it.
It's a stiffer, much stiffer tip because it has the balloon mounted on it. So when you track around these very angulated arteries, you really need to have a fair amount of wire in there. You don't want to just use the tip of the wire, and that's another technical tip I think that's very useful with these balloon catheters, particularly this one. So we're going to take the wire out, and then we're going to do a quick little angio just to see if we like where we are, and then we'll inflate the balloon.
Let me.
I mean, that was a great
a
point
good
you all made about the TUI. I don't know how common knowledge that is. I actually didn't know that. I'll totally confess.
That's
And
nice.
so I've always used the sniper through a TUI, and I've
I have
had
it here.
times where I've had a little bit of difficulty tracking it. So I wonder if that attributes to that.
So it's definitely more so on
Do the nitro
radial
first.
length. On the femoral lengths, it doesn't seem to be as big of an issue. Just obviously there's more coating on the longer catheters.
Yeah, sure.
But we've definitely seen that and have gotten like stuck inside. You can get it out, right? But you just can't get it, or meaning you can pull it, remove it, but you can't get it through the base catheter.
I'm giving another 200 of
Yeah.
nitro into
Yeah.
the
It can
kidney.
be quite frustrating.
So we're putting a little more nitro. With 200 of nitro here just before we inflate the balloon. We're going to zoom in on the balloon, and Tim's going to inflate this for us very slowly. We use a 0.25 cc syringe here with 50-50, and we're just flushing the nitro right now. And then we're going to watch the balloon go up. Usually the balloon goes up very slowly, and then it pops open. So we're going to watch and just do a little bit. And if you guys could focus on our hands here while we do this. Just a little bit closer to that blue thing on the syringe.
Can I get the rest of the DMSO, please?
And we're looking at that black dot there. And once we see the black dot with a little contrast around it, we're going to stop and lock it.
Ellie, where's the rest of the
Sometimes there's a little air in the balloon, even though you prep it really, really well. So Tim's going very slow here, just so everybody can see.
This is as slow as I injected the lava.
If you happen to inflate the balloon,
I had the patience to do that.
Tim is very patient, Covey.
Yeah.
He wins the patience award,
Yeah.
actually.
He's definitely more patient than me and Rahul.
And perfectionist.
And even Dr. Garcia, I would say.
And I think we're probably close.
You think it's up?
Comment on Kirema's patience.
Maybe a tiny bit more. I don't see the contrast yet. And I apologize, I prepped this before. So I'm pretty good at prepping it, but it's also possible a little bit of air got in there.
Contrast in the...
I don't see anything.
I see
So
contrast.
this is actually my challenge as well. I tend to go a little bit more than 50-50 contrast in the syringe. That helps me a little bit, but yeah, I mean, this is always my challenge also.
Look, here's the thing. We can start injecting the embolic, and then if we see it refluxing and it's going past the balloon, oh, wow, look at that.
Oh, there you go.
You were right, Tim.
Yeah, I mean, the other thing
So
is
what happens is it goes open slowly, right, Rahul, and then it all of a sudden opens up.
So the other thing is even though the two lumens don't communicate,
Let's just inject
pressure,
the DMSO.
I have it here.
The pressure of injecting the injection port will push on the channel for the balloon, so you'll get a little bit extra inflation as you inject the.
Now there's a small off chance that we ruptured the artery here. If you look at the way that the balloon deformed the vessel, it's bigger than the vessel. It's also possible that just the elasticity of the vessel, which is usually what happens. But even if we did rupture the vessel, it's not going to make really any difference because we're going to embolize it on the way out. So
I'm sorry. Did you do a run with the balloon up? I didn't see that.
We did not.
It's okay.
We're just going to go ahead and embolize.
All right, sounds good. And then what's the dead space on your sniper there?
So the dead space is going to be about 0.46. I believe. I could be wrong about that.
I think the sniper is a little bigger. I think the sniper is almost 0.6.
I agree.
.6?
In the
Over
one,
0.6.
yeah, in the 150.
In the 155.
You stand corrected.
Okay. I guess I don't know the answer to that question, Rahul. I should know. The DMSO we can inject faster than the into the catheter, faster than the way we inject the EVOH, right? Because that we're just flushing out the saline in the contrast.
Yeah, so you can inject like the first 0.5 mLs pretty fast because you're just flushing out the saline. Exactly. And then the last bit, you have to go a little slowly. Yeah.
Weren't we just talking about patience?
Well, you know, Tim is perfect for using EVOH because he has more patients than we do. It's not always the case with everybody else.
It's actually how they decide the fellows for the cases.
Embolic.
So
based on
why we embolize this vessel, and I'm pretty sure this is going to finish off this one medial tumor. This is the one that was larger, and I believe it is also more vascular, which is good. The smaller one is approximately 4 centimeters in diameter. It's the one more lateral. I think we probably have to go maybe past that other branch that we were in before, and then take out. I think there's probably 2 branches there. Is my best guess. So we could do that with a balloon catheter. We could do it with an end hole catheter. I'm not really sure. Unfortunately, we have to use multiple microcatheters here, which is one of the downsides with using this type of liquid embolic. If we were using particles, as many of you know, we would probably be okay using the same microcatheter each time.
Correct.
Yeah. So it is a downside. Rahul, do you have any comments on that in terms of cost and things like that?
I agree, but right now, at least what's available in the U.S., this is the only liquid that's going to go this distal. That's FDA approved, right? The conformables won't go that far. It's not designed to go that far. I know people have done. Correct. Mm-hmm. Yeah.
Look at that.
Okay.
So you can see the difference here, like the way it's flowing. Right before, it kind of was running away from the microcatheter, and when the first smaller branch, and now it's kind of making like the lava, like the actual lava, right? Like you can see it sort of flowing and then pushing forward.
You can actually inject pretty fast with a balloon catheter. I'm just trying to give us a better view here. That's probably better.
I like that.
Maybe this way. I like that. Yeah. It's pretty good. We're probably going to get a lot in there.
I know you guys use a lot more liquids now, but you all use a lot more liquids now. But anybody had a post embolization recurrent or bleed, rupture, anything like that from a slightly more proximal pseudoaneurysm, something along those lines? I know it's reported in the literature. I know people have seen it with more particle embolization. I would assume that would be an advantage of liquid embolization here as well. Yeah.
I mean, I guess that's a good question though. So if you see on your angio that the patient has multiple little pseudoaneurysms or even bigger pseudoaneurysms, would you still use Lipiodol alcohol, or would you switch, or I don't know.
I would switch. Yeah, I would probably switch. And I mean, the other question I have for you all, I mean, would you use an adhesive or a cohesive embolic from a liquid standpoint?
I don't know that it matters that much, honestly. I think they would both be okay. I mean, we know that NDCA causes more vascular damage than EVOH, but I think they're both going to occlude the vessel, and I think they would both work. Well, so what are we seeing here? What do you think?
I mean, I can still get more in. It's coming around there.
Yeah, we're going to keep going. Yeah. I mean, we're taking our time here, but I think we can get more in. Yeah. The other thing we're going to probably do at the end is we're going to take the balloon down, and then we're going to try to just put a little bit in the parent vessel.
Can I get the rest?
Just in
case the rest of the lava, please?
It's ruptured. Yeah.
Yeah, I'm almost done with this syringe.
That's a beautiful fill.
You're getting a real nice result there.
Yeah. I feel like I don't. I need to adopt the Tim technique, and the patience.
Everybody needs their own Tim.
Right?
Yeah.
This is Tim's last live case, right?
This is the part where the attending.
Actually, I think it's Tim's last day, right? Doing procedures at Maine.
Now it looks like
Okay.
we're going
Well,
around
he's
the
done with that
periphery of the tumor.
Yeah.
So
Think.
really
So,
nice.
so
See,
Aaron,
it's still going up there.
yeah.
Tim,
So
can you switch with me?
we use a lot of liquid embolic, so this is pretty easy for us. But what would you say is the learning curve? I guess more so for Tim, I guess. What would you say the learning curve is for people who, if you don't use it, how many cases like?
Yeah. Well, it's a little bit daunting, I think, to use EVOH in the beginning because you have to prep the catheter with the DMSO, and the DMSO can cause spasm, and sometimes if you're using it in the patient's awake, they can feel it. But this is a really good embolic agent when you want to be very controlled about your injection and you want to try to save as much tissue as possible. It's not critical to use it in the kidney, I don't think, because we can do these cases and take a little bit of normal kidney and be okay with it. I think if you're using NBCA, it's a little bit more unpredictable, particularly in people who haven't used it before, and so that's definitely pretty daunting. I'm going to rotate this a little bit just so we can see that catheter.
Tim, what are your thoughts on that?
On learning curve, yeah,
Yeah.
I think Onyx and Lava have a little bit less of a learning curve than MBCA, as long as you've got sort of somebody who's more familiar to show you. I think
That's better.
the actual like mechanics of learning NBCA are slightly easier in terms of prepping the catheters and prepping the material, but in terms of being forgiving, as long as you've got the patience to go this slow, Onyxes and Lava and these embolics are much more forgiving from a learner's perspective, because glue, you have to get it done all at once, and quickly and right the first time.
So what do you guys think about an endpoint here with a balloon catheter? Because we don't really know what our endpoint's going to be because we're not really seeing any reflux.
Yeah, we're starting to like fill a blob there, though. I think we're
Yeah, I think that's probably
I think
done.
yeah.
So we're going to take the balloon down, and then we're going to try to just put a little bit in on the way out.
Where's the syringe?
I think the other thing that I'd mentioned too that's nice with MBCA is just the ability to aliquot, right? And obviously you don't have that capability here.
Yeah. So what would you say is like a good first case for Lava? I don't know if this is necessarily a good first case if you've never used it before. Yeah. Okay. Because the original study was GI bleed, right? Yeah, it was this. Yeah.
That's what I would say.
Yeah.
Yeah. Yeah.
Yeah.
No, I agree. Rectus sheath bleed, I think, is a perfect area because you usually have your base catheter seated in the inferior epigastric origin, and you can yank your microcatheter quickly if things go a little bit sideways, right? So I think that's a really nice space to try to start. No, Endolink is great.
Yeah.
Yes.
Yeah.
Yep.
This question when you're using a liquid, even if it's non-adhesive like this and cohesive, that you could get your catheter stuck. Typically with these products, you have more than 30 minutes before it's really stuck in there. Not with MBCA, obviously. But we're trying to just move the catheter.
Yeah, I mean with
not stuck.
Yeah, it's entrapment, right? Like it's usually you get spasm
Yeah.
around the back of the vessel and the lava comes around it. There are definite reports. I mean, it's actually
Info?
it has happened
not
to
coming.
us, but it seems to be in like a very specific situation where you get spasm behind your catheter and the lava just packs in and squeezes down on the catheter. But usually you're able to
It's
get it
coming out.
Yeah. Yeah.
Balloon's still up.
Your balloon is completely down?
No, the balloon's still up. That's the problem.
Okay, so let's, yeah.
Sometimes the balloon doesn't come down because it's stuck in there. Let's take a look.
Yeah. It's a very small lumen, right? You have to. That's
It
the
almost
reason for
feels
not.
like when you're pulling these out, it's like you're stuck in like the mud and you have to put gentle traction on it.
Yeah.
There's still some air in there.
Or if you open it.
Well, and I think I think Rahul made this point
Done it
earlier.
3 times
The
like this.
lumens in the
It's a
catheter actually I think collapse into each other a little bit.
Yeah.
And so advancing one thing through one lumen can sometimes affect the other lumen slightly. It's just something to know about the catheter.
Yeah. Yeah.
Trust.
Yeah.
Yeah. I mean,
Yeah.
the issue with glue here is that you can't be this patient, right? Like, you would never be able to leave it like
I
this.
think we popped out of the renal. Let me push it back in.
Yeah. Well, that being said, Rahul, I mean, I tend to let,
Back up.
when I'm using Onyx, I
Rub
tend
this
to let
out.
it set up for,
Yeah.
I don't know, 10, 15 seconds before I yank I mean, obviously we did
Yeah.
for a little bit longer here, but it's definitely not a inject and pull the catheter, right? So.
Yeah. Exactly. Yeah.
Look at that. So we got to go back in.
Yeah.
There's more.
What do you want?
Let's get that actually might be a little rupture there.
Rupture,
Yeah.
yeah.
So let's get a true select LU, a 150.
Should glue that.
What do you want to do?
Don't glue that. That's
Yeah, we could use. What do you think? Probably something fast.
Yeah. Probably.
What do you think? NBCA?
Yeah.
Let's get a little
Is it really
NBCA.
or is it just more
City or
AML?
I don't know, Ruhul, but either way, I think.
Yeah.
Well, no, we have this. You know what? We'll just put this. We have a lot left here, so we'll just use that.
We still have another
I
IML.
think, I mean, that looks like it was from the balloon site, right?
Yeah. Yeah.
I think so. That was what I was suspecting earlier
Yeah. The way it popped. Yeah.
when we inflate it. Yeah. No, we're just going to use the DMSO and the lava. Yeah.
You ready, Tim?
Mhm.
Here you go.
Although I guess, Aaron, now you sort of regret not having a guide, right? Because you would have been able to not
Yeah.
pull the balloon.
We talked about that before the case, Rahul.
I know.
And I
No bickering. Just family.
and send wire.
You're leading with wire.
Thanks.
I think, actually.
But this is a great, and we can sort of show how long it takes to use EVOH in a case where you want to be faster than slower. So we'll see. I think we can get in. It's going to take maybe a minute or two to get in,
How much wire are you?
but once we get in, I think it'll be
So
okay.
it's a great time to kind of pose this question for those, historically, like we never got trained on Onyx and glue, right? I mean, there were nerve products and there wasn't a lot of, peripheral training available unless you used a lot of them in fellowship or in your, local institution. So if you don't have access to liquids or not comfortable with liquids, what kind of coil what are you going to use here?
Yeah. Coil.
Well, I shouldn't say coil. What kind of coil or plug or something else?
Yeah.
So. No, I mean, I think you have options, right? Just depending on what kind of catheter you get in. Yeah. You could also, I mean, a 3 MVP, something like that. Maybe, I mean, you
Yeah.
have options here depending what you have on the shelf, but yeah.
Yeah. I mean, here at this point, you're just going to take out the vessel, right? It's not an
Yep.
intra AML rupture,
Yep.
right? It's just. Right. But you could get to it though and inject it and let it just percolate around your catheter, right? And come back in rounds, right? And reflux. Yeah.
Yeah, I agree.
You might have. It's hard to. That's sort of the problem, right? You don't. It's hard to predict for this because like if you just injected it really slowly, it'll probably go pretty far because the flow is fast enough. Like it'll take it, right?
I don't have Tim with me, so I don't know that would be true.
Yeah.
But I mean, I think you're totally right. That's a great
That's
point.
it,
That's
right?
that might be the other one.
No, I think that's it. No?
I don't think so. Find out.
Here.
Could be. Yeah. Okay, that's it.
You think that's it? I don't know.
I don't know.
Let's take a look.
Let's see.
Let's just look.
It's a little different.
Yeah, it looks a little different.
Contrast.
Yeah.
That's it.
Hello.
All right. Beautiful.
Back up a little bit.
We decided we're
Let's do
using the rest of
DMSO.
us.
We're going to do it like a GI bleed. That's what Cubby wanted anyway.
Like a GI bleed? I didn't ask for a GI bleed.
Yeah.
We did not. We agreed, both Dr. Krishnasamy and I, we would have started with the inferior epigastric bleed.
Oh, who said GI bleed? Rahul?
Rahul said that that's why it was
No,
approved for.
That was what the original approval.
just
Well, it's not
flush the
GI bleed, it's
first.
bleeding, right? It was-
Bleeding.
Bleeding,
Yeah,
yeah.
not GI specifically.
Yeah.
This looks a little funny.
Well, that's another great question. I mean, you're treating multiple vessels with onyx or lava. You're using multiple microcatheters. You know, is that cost effective in this day and age? You know, I'm lucky. I don't have to worry about that, but not
Yeah.
everybody else has that luxury. So
Yeah, no, of course. Yeah, I mean, I don't know for like a run-of-the-mill, colonic bleed, like is lava more cost effective than maybe one or two coils? Although,
Yeah.
the cost of the coils now, depending on what coils you're using,
Yeah.
2 coils will get you right up to the cost of lava. The issue
Absolutely.
with coils though, and sort of why we use a lot of liquids is that it's somewhat dependent on the patient's condition, right? So if they're on, Coumadin or, on some sort of anticoagulation, the coils don't work as well. You also end up with a situation where you put 2 coils in, you don't have any space, but it's still flowing through your coils, right? And you either
Yep.
be patient and hope that the fiber's occluded or figure something else out, right? And so that's where lava or glue are nice because you don't really care. The patient can have have an INR of 10 and it'll still work,
yeah, that's a good point.
Initially, we were saying how cannulating 3 different vessels to treat these 2 AMLs, at least 3, may have been too acute to do this case. And so, what's your thought at this point about just taking that whole lower branch, which includes the other branches that are feeding the AML? What do you guys think?
I think if you get control here, I mean, I'm always looking at this from sparing as much kidney as possible. I mean, young healthy females. So, I would probably go after them individually if you get control here. If something happens and you don't have control here, I think you take the whole branch and there's nothing you can do about it. Rahul, what do you think?
Yeah, no, I agree. I think if you can try and be more selective, it's always great. At some point, though, you end up with diminishing returns, right? You're saving, 1 or 2% of the lower pole or of the
Sure.
left kidney, and you're like just a lot more radiation, a lot more contrast to and time and all that stuff. So.
Be nice to have a guide cath.
I know, it would be.
So in terms of guide cath, we can talk about that. There's a couple different options. There's a runway guide cath, which is 6 French, which is 110 centimeters, which we use a lot. They come in JR4 shapes and MP shapes, as well as a femoral shape. And then there's Cordis makes Merit. Which one? The FR4?
Yeah, they make an FR4, but not a JR4, right?
Yeah.
Thing, but
I think they make both. And then there's also the Merit Concierge line, which goes up to about 100 centimeters, I believe. And that comes in all different shapes, including the ultimate shape, the Sarah shape, which is the same as the Sarah shape, and then Cobra shapes and things like that. And then there's the Cordis line, which is somewhat new. And those are, I believe, 115 in length.
I think Asahi also makes their UCAF.
Yeah.
Their UCAF also is the sheathless guides.
Rahul, I haven't
going
used a
lateral.
UCAth. I've just played with it on a table once or
You
twice,
guys
and
happy with this?
I haven't found the tip to be super flexible. But
You guys are
maybe
happy.
I'm mistaken in saying that.
Yeah, I haven't really.
I wasn't as happy.
Yeah, we haven't really used it, so I can't really
Okay.
comment. But I agree that I wouldn't necessarily feel super comfortable driving that catheter around some vessels, right?
Yeah. Yeah.
But
Yeah.
doing it
Tube
like
City
this,
over
where you're just going to park it into the renal and just leave it there, that's probably okay.
Yeah.
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 Because you got to remember, it's
And
designed as a
just
coronary guide, right? So coronary guides are
exactly.
designed to just parked in the right coronary.
Exactly.
It's not included.
Probably
Actually, you
need
should
more.
know.
Exactly.
Just
You
do
did
it. We'll do
cardiac
it
cath,
ASA.
right?
Let's just do a flush, actually.
That was a
Flush?
long time
No,
ago,
no, just
but
flush.
yeah, I've done some, but yeah.
Yeah.
But it's a good segue, from as you're passing a guide up the arm from a radial approach, what is your technique? Do you worry about a razor effect? Or just let it go if it goes? What do you typically do?
Yeah, I mean, again, it's sort of the general IR technique. If you push
Yeah.
gently, and if it doesn't go, don't keep pushing, right? You're probably
Yeah.
stuck, and so you can load them with a diagnostic catheter.
Definitely.
The cardiologists talk about using the bat technique, right? So they use a balloon,
Yep.
put an 014 wire, an 018 wire, and put it with a balloon to use into the operator. It's kind of annoying for us because we typically do everything over an 035, and then you have to switch to an 018 or an 014, and then put a balloon in.
Yeah.
But yeah, usually you can get through a 6 French guide. You can sometimes get like a 5 French glide cath or a 4 French glide cath, and that gets rid of the razor effect. The other sometimes just spin the guide, right? It'll get it off the edge.
Yeah.
Yeah.
That's a great
Pretty
great
much
point.
the entire lower pole. There's no non-target at all, and it doesn't look like anything's really bleeding there.
That's fantastic.
Yeah, it's great.
Yeah.
We have this other lesion we can go after. We probably should do that while we're here.
Yep.
And preserve the that main trunk that goes to the lower pole. It's
I
up
get
to you
another-
guys if you want to. I'll leave it up to you, Rahul, if you guys want
Well, I
have
think
any more
we're-
questions or if you want to watch that part. We're getting
onto
close to the end of the hour, I believe.
Yeah, we're getting close to
Yeah.
the end of the hour. So I think, look, you could also make the argument that it took you an hour to do this, which is a great result, and I think it's still pretty quick. But maybe you can also stage it, right, and do one now and one later as well, right?
Yeah, I mean it's hard for me at this point, given that we have a catheter here in the artery, just to
Of course,
ignore
yeah.
it. But yeah, we could do that. I think that it's not unreasonable.
I'm not saying to do that. I'm just saying you can make that argument.
You definitely could make the argument, but I wanted to demonstrate how to use these newer agents for cases that maybe you wouldn't necessarily think of initially, and so I think this is a good example of that, and it definitely shows the advantages and disadvantages of different catheters and different embolic agents. So I'm really happy that you guys were able to comment on it and to watch.
Yeah, and I think it's a great result.
Well,
I think oh, sorry, go ahead, Kavi.
No, sorry. I mean, I totally agree, and I think it's also very timely, right? Because for those of us that don't have neuro IR in our hospital, now we have access to a liquid embolic, for peripheral use. So it's fantastic.
Yeah, exactly. I agree with Kavi. To show sort of the newer uses of these, not necessarily newer embolics, but sort of new approved peripheral embolics. It's good to see some different areas of where we can use it outside of what the study was, right? And some different indications for it. So, yeah.
Yeah, thanks.
Thanks. Throw an hour
No,
back.
it's
huh?
not.
Okay.
I'm an hour behind.
Yeah.
No, I appreciate
you're
it.
on the
Thanks for having
moon.
me. I definitely learned it.
All right.
Definitely learned a thing or two as well. So hopefully the audience benefits. So it was a great case.
All right. Thanks, guys.
Thanks, guys.